Welcome to ATS's webinar on CPET. Today we have Dr. Kathy Sietsema, investigator at the Lundquist Institute and professor of clinical medicine at the David Geffen School of Medicine at UCLA. We have David Systrom, assistant professor of medicine at the Brigham and Women's Hospital and Harvard Medical School, and Richard Casaburi, at the investigator at the Lundquist Institute as well, and professor of medicine at David Geffen School of Medicine as well. Since we are a little pressed for time, I'm just going to start off with Dr. Sietsema. Would you like to start us off?
Happy to, thank you. Let me share my screen and get started. So this webinar is related to changes that have occurred since the publication of the statement by ATS ACCP on clinical exercise testing that was published in 2003. So there's been a lot of time passed since then, and we were each asked to talk a little bit about changes that have occurred over the last 20 years, which is a bit of a tall order. This is the outline of that statement as it appears in the beginning of the publication. And you notice that one of the first sections is on the indications for cardiopulmonary exercise testing. Some of these are clearly diagnostic uses: unexplained dyspnea, evaluation of bronchoconstriction. And I'm not going to discuss these. I think David will have a lot to say about the evaluation of unexplained dyspnea. I'd like to focus instead on evaluative uses of cardiopulmonary exercise testing. And by that, I mean testing that we do when there's a patient who has a known diagnosis or a circumstance in which there's reason to believe that the results of CPET can be useful in clinical decision-making and management. And I'm going to focus on these two areas, just cardiovascular disease and preoperative evaluation, because there's quite a long list of things here that are hard to all address. So in the section in our publication on cardiovascular disease, the main discussion focuses on using CPET to help rate the severity of impairment and estimate prognosis among patients with chronic heart failure. Now, this comes out of some very well-established data from the middle of last century, the 1970s and 80s, in which it was well established that in individuals with heart failure, you could identify better or worse prognosis based on better or worse exercise capacity. In this case, stratified by peak VO2 values above or below 14 mils per minute per kilogram. Now, this formed the basis for Mancini and colleagues in the 1980s and 90s to use exercise testing in stratifying their heart transplant waiting list. And they found that by deferring and not doing transplants in individuals whose peak VO2 was above 14 per kilogram, those patients subsequently had as good a 2-year survival as individuals who had undergone transplant during that same period of time. So this is really a landmark paper, not just a practical tool for the heart transplant programs, but it kind of proves the concept that we can do clinical CPET even in very sick people, and the data are robust enough to support clinical decision making. Now, this use of CPET remains well supported. Most guidelines published about heart failure since the mid-1990s include CPET as one of the tools that are used in patient evaluation, and the applications have widened beyond reduced ejection fraction to include preserved ejection fraction heart failure. In addition, there has been a lot of interest in variables besides peak VO2. So it particularly focused attention on the VE-VCO2 relationship, which has prognostic significance and may be as powerful a predictor of survival as peak VO2. Oscillatory breathing, anaerobic threshold, and other variables are also of prognostic significance. And so this work over the last 2 decades or so has given rise to a number of recommendations and strategies for combining variables into some aggregate measure of exercise function to be used as part of the prognostic assessment in patients with heart failure. The other thing, of course, that's changed over the last 2 decades is that the care of heart failure has evolved substantially, and both medical care and the options for advanced interventions have evolved a lot. And with that, the prognosis of heart failure has improved substantially, so that we now have to go back and ask whether a peak VO2 of 14 per kilo means the same thing now as it did back in 1991. And it clearly doesn't, as illustrated by this figure from European Journal of Heart Failure a few years ago, in which the authors have distilled data from published literature and give us sort of composite lines identifying the relationship between risk and peak VO2 or VEV-CO2 slope for decades, from the 1990s progressively towards the current day. So we see that there's, for a given level of peak VO2, the prognostic significance has shifted to the left, so that now the risk associated with 14 mils per minute per kilogram in the 1990s is more like 10 or 12 mils per minute per kilogram. So this means that there has to be a recalibration of the standards that are set and the relationship between CPET and whatever it is, the condition that we're looking at. There is no mention in the 2003 document about using CPET in congenital heart disease, but over the last 2 decades, there's been lots of studies reporting CPET in these conditions. It's a very diverse set of conditions. Not surprisingly, there are a number of reports looking at prognosis, and not surprisingly, peak VO2, as well as in this analysis, heart rate reserve, are significant predictors of prognosis. This is an example from a study of about 1,300 patients with a variety of congenital heart diseases, but there are also studies in other specific populations showing that exercise testing is helpful in prognostic assessment in the congenital conditions. In 2008, and then updated in 2018, the Cardiology societies publish guidelines for the management of adults with congenital heart disease. And in this document, CPET is mentioned in a number of places. So, for example, the most common recommendation for the use of CPET is simply for establishing an objective measure of baseline functional capacity, and then using that serially to follow stability or worsening of impairment over time. And that's because even knowing a patient's diagnosis, their anatomy, and their history of what they can or can't do, it's very difficult to get an objective assessment of function without an exercise test. There's also a section in these guidelines regarding sports participation, which is a big deal. And CPET is identified as one of the tools that may be useful in informing the discussion between clinicians and patients about participation in sports and exercise, risks and benefits, and expectations related to that topic. Finally, most of these guidelines are organized in terms of the specific anatomic diagnosis, and in each of those sections, for each diagnosis, atrial septal defect is the example shown here, there's a table such as this that makes recommendations about the frequency of routine follow-up and testing. And in most of those tables, maybe all, there is a row for exercise testing, and the frequency recommended depends on the patient's diagnosis and their clinical status at the time of follow-up. So there are a number of pretty well established and recommended uses for CPET in patients with congenital heart disease. I will mention one other, and that is risk stratification for specific anticipated stresses. And the example shown here is risk stratification related to pregnancy for young women with congenital heart disease. This figure is taken from the a seminar on obstetric care for congenital heart disease published by the American College of Cardiology. And it identifies CPET as part of the preconception assessment, and they actually recommend some threshold values from CPET above which patients can be expected to have a safe pregnancy, both for mother and baby, peak VO2 above 25 per kilo and a peak heart rate above 150. So let's switch now and talk a little bit about preoperative assessments. Most of the discussion in the 2003 document about pre-op assessment is related to candidates for lung resection surgery for lung cancer. And what I've shown in the upper right-hand corner here is the current or most recent CHEST guidelines from 2013, the algorithm for assessing patients with pulmonary function, and sometimes CPET, in which the CPET is used to stratify patients into high, medium, or low risk based on the peak VO2 value measured. There's a similar sort of algorithm published by the European Respiratory Society. It front loads the process by putting exercise testing a little bit closer to the beginning of the process. These recommendations have stood up pretty well. There's meta-analysis from 2007 and 2023, both of which seem to support this use of CPET and the characterization of risk based on peak VO2. However, what has changed in this area over the last 20 years includes a shift towards more minimally invasive surgery, including lung resection through VATS, for which the risks could be expected to be lower than for thoracotomy. So this leads us to question whether there should be a change. Is it still valid to use peak VO2 as an assessment of risk? And is there a change in the values that represent higher or lower risk in this setting? And there's not a lot of data to go on for this question. Are data such as shown here. This is from just a couple years ago. This is a retrospective review of about 600 patients who underwent VATS lung resection. And these investigators found that indeed exercise capacity did predict risk, and there was greater risk of complications for those with lower peak VO2s than those with higher peak VO2s. But the discriminative value wasn't particularly good. So here we've got the receiver operating curve, and the area under the curve is about 0.63. So sensitivity and specificity for any given value of peak VO2 in predicting complications is not as good as some of the other factors that they looked at, including just the extent of the resection and some other clinical factors. So I think the jury is still out on the validity of using CPET in this setting and exactly how the variables should be used in risk assessment. In the 2003 document about CPET, there is a mention of using CPET in the pre-op assessment of other types of surgery besides lung resection, but it's really only one sentence, and it contains one citation. The citation is to a paper from the 1990s by an Australian anesthesia group who performed pre-op evaluations in patients who were considered high risk for major surgery and found that AT was predictive of perioperative mortality. There is a follow-up study from the same group in which they used this observation to stratify where patients would go post-operatively. So the patients who had pretty good exercise capacity might be put into a lower acuity setting for their post-operative care, therefore saving resources. And they found that they could do this without any increase in morbidity or mortality. So these studies garnered a lot of interest. And in the next couple decades, there's actually been quite a bit written about using CPET in risk assessment for patients going elective but high risk surgical procedures. This figure here is just a distillation of some of the findings that were reported in a systematic review from the British Journal of Anesthesia in 2016. This reflects data from 37 studies comprising about 8,000 patients. The surgeries that are reported include a variety of different procedures. The outcome measures were not all the same, but arguably these are really all very important outcome measures. And although a whole range of CPET variables were measured, this literature tends to focus still on the anaerobic threshold, maybe reflecting those early reports from the Australian group. And there's a fair amount of consistency, I think, in the findings, in that most of these studies find a threshold value of between 10 and 11 mils per minute per kilo for the anaerobic threshold on cycling exercise to be the value that below which there's an increase in morbidity and mortality. So this seems to be a fairly well accepted indication for CPET now. There's a set of consensus clinical guidelines published in British Journal of Anesthesia in 2018 by the Perioperative Exercise Testing and Training Society, POETS, so they've got their own society, suggesting this is a going concern. Before I end, I just wanted to make one comment about pediatric CPET. I searched the 2003 document and couldn't find the word pediatric, but there's been lots published about CPET in pediatric groups in the last 2 decades. The range of conditions for which the CPET's used overlaps considerably with what is used in adult populations, but clearly the logistical and clinical considerations of pediatric groups warrant a little unique treatment in any future document that might be produced. So those were my comments about 2 of the evaluative uses of CPET and how they've evolved over the last 2 decades. There are other things that we don't have time to go into, but are equally important. And with that, I'll thank you for your attention.
Thank you very much, Dr. Sietsema. Dr. Systrom, would you like to start?
Absolutely. Well, I'd like to thank the organizers for the invitation, and I also want a special shout out to my co-speakers here. Kathy, good to see you again, and Rich, for everyone, they taught me everything I know about this business back in the day, so it is an honor and a privilege to be on the virtual podium with you. My mandate here was to cover some of the recent developments using invasive cardiopulmonary exercise testing with a bit of a focus on some interesting findings, we believe, in both ME/CFS, that's chronic fatigue syndrome, and long COVID, especially the latter, which has seen the light of day most recently. So another call out to a special place back in the day, the Harvard Fatigue Lab. I guess what goes around comes around. Very interesting place to put many of the basic tenets of non-invasive cardiopulmonary exercise testing on the map, most of which have withstood the test of time here. This is the basement of where I work now, the Brigham and Women's Hospital and Harvard Medical School. And just very quickly, we'll show you some highlights of the invasive portion. So here's what Dr. Sietsema was referring to, but the non-invasive version of this test is a pneumotachograph and expired gas line, measures breath by breath, pulmonary gas exchange and minute ventilation. And what's added in the invasive test is a radial artery catheter and a pulmonary artery catheter, always placed in the internal jugular vein, in the cardiac cath lab around the corner from the exercise lab. The patient then rolls around and does a traditional incremental cycling study, occasionally on the treadmill, but for the most part on a stationary cycle. Here are some of the measurements that most in this audience will be aware of, some of the non-invasive variables, the expired or the VO2 peak, for instance, the CO2 output at the mouth at peak exercise, minute ventilation. And then what is added by the 2 catheters are things like the arterial oxygen content, the mixed venous oxygen content, pressures, including the transpulmonary gradient. These are helpful in some things I won't be talking about here today, exercise pulmonary hypertension is one, exercise heart failure preserved ejection fraction, where these are elevated respectively, is another. Right atrial pressure, you will see, I hope, in the course of my talk, to be relevant to ME/CFS and long COVID, and we get right ventricular pressure so that we can do a lot with in terms of finessing RV function and pulmonary vascular uncoupling. Here's sort of a dumbed down algorithm for our invasive CPET. The top part is non-invasive, so there's the VO2 peak, and I'm not sure if this is in the way of everybody, nor am I sure how to get rid of it. But anyway, the VO2 peak, of course, gives us an assessment of overall impairment. You can finesse the number as a percent predicted that you may use as a cutoff for abnormal. I will say, anticipating some of what I'm about to tell you, that patients with ME/CFS and long COVID often have relatively well-preserved VO2 peaks. So be careful in writing off a patient, as it were, who comes to you and has a non-invasive CPET and a VO2 peak of 70 or 80 or even sometimes 90% of predicted. There may be some findings we can uncover with the invasive variety. Pulmonary mechanical limit, I'm not going to talk much about. There are ways to measure that with parenchymal lung disease. Most of what I'm going to talk about relies on the Fick principle, which is shown here, and suggests that the VO2 peak can be depressed by a depressed peak exercise cardiac output, QC, or any abnormality of the difference between arterial and mixed venous oxygen extraction. So if we flow down this diagram, we can see that there are central cardiac limits where there's a matched decrease of the peak exercise cardiac output and the VO2 peak. And then these are intuitive. You can use pressures like a surrogate for the left atrial pressure to determine whether the left heart is limiting you, the mean pulmonary artery pressure and the pulmonary vascular resistance to determine whether pulmonary hypertension is limiting you. But what I'm going to spend most of the time talking about is this entity, preload failure, where there appears to be inadequate filling of the right heart, failure to prime the pump, as it were, in the upright position during incremental cycling. And then additionally, abnormalities in the periphery on the arterial side of systemic oxygen extraction, which can be normalized for anemia, shown here. We began to get into this business several years back when, with referral patterns at the Brigham, we determined that there was a subset of patients who had exertional intolerance that couldn't be accounted for by any classic limit related to heart or lung disease. They complained of exercise symptoms. We couldn't find anything wrong with the heart or the lungs. So we pursued it with this study back in the day. We had a cadre of normal individuals shown here. I'm going to cut to the chase with their invasive hemodynamics. This is the right atrial pressure at rest for the category of normal individuals, and those who didn't have any heart or lung disease but had a depressed peak exercise VO2. A VO2 peak was impaired. And what differentiated them was not so well seen in the upright position at rest, but at peak exercise, we saw abnormal right heart filling denoted by the lower right atrial pressure, and we had the similar phenomenon over on the left side with the pulmonary capillary wedge pressure depressed at peak exercise in the upright position. And when we attempted to regress filling on the right side and the left side against time-honored cardiopulmonary exercise test variables, the VO2 peak here and the cardiac output peak here, there was an association. So the lower the filling pressures in this impaired group, the worse the VO2 peak, and the major mechanism appeared to be depressed peak exercise cardiac output. So this is where they land in our algorithm. This is what we come to call preload failure. I'm not sure it's the perfect name, but it appears to describe at least some of what's going on in this patient group. So in ME/CFS, and we determined in retrospect that most of these patients met IOM criteria for ME/CFS. Their major problem, underlying exercise intolerance, was preload failure. Took a little deeper dive into this 2 summers ago with this study led by Philip Joseph, now at Yale, and we did a couple of other things. A little deeper dive into the hemodynamics. These are tertiles of cardiac output versus VO2 slope. This is analogous to something that's been done in POTS during an upright tilt table test. And here's a group of normal individuals who underwent the invasive CPET. They complained of symptoms. We couldn't find anything wrong with them. It's been known for a long time that the normal slope of cardiac output versus VO2 is about 5 to 6 ml per ml. And we divided the affected patients with well-defined ME/CFS into tertiles. This is the interesting newer group. This is the preload failure group with very low cardiac outputs at peak exercise. There was an interesting subgroup of patients with high cardiac outputs versus VO2. And remember, what we're measuring with the FIC principle is pulmonary blood flow here. So high pulmonary blood flow, and associated with that is impaired systemic oxygen extraction at peak exercise. We took a further step in trying to define whether there was a neurovascular dysregulation, meaning autonomic nervous system dysfunction, by doing skin biopsies in a large subset of these patients. And we can define small fiber autonomic neuropathy by a decreased density in the skin, in the epidermis of the neurites. So slam dunk is less than the 5th centile, and probable is less than 15. And what we found was a large percentage of patients, about 45%, with definite or probable small fiber neuropathy underlying the preload failure and this peripheral abnormality. And this is where these patients land. So this is all ME/CFS. This is patients with both preload failure and with the invasive CPET, impaired systemic oxygen extraction. So our interval conclusion here is that in ME/CFS, this exercise intolerance is associated with preload failure, a subset with left to right shunting, and a high prevalence of this small fiber neuropathy, small fiber nerves known to regulate blood flow during exercise. So we conclude there's the potential for neurovascular dysregulation. We took this a little step further a few months later with a randomized placebo-controlled study using invasive CPET. I would hold this out as a paradigm for some of our future work in this business. We used a drug, FDA-approved drug for myasthenia gravis, pyridostigmine or mestinon, which is known to enhance acetylcholine at the synapse of the sympathetic ganglion. Remembering that the postganglionic fiber that regulates, amongst other things, venoconstriction, but also arterial constriction during exercise, is adrenergic. So we enhance a cholinergic step, but ultimately think we might be enhancing adrenergic tone of the blood vessels. So we did this study published in Chest and measured peak exercise VO2 after drug, pyridostigmine here, or after placebo in about 50 patients with ME/CFS. If they got drug, the VO2 peak after drug with a second spin of the exercise cycle with the existing lines in place was higher. The effect size is small, but remember, this is a single dose, 60 milligrams of mestinon, and they pedal 45 minutes later. If they got placebo, they were actually a little bit worse. The mechanism by which the VO2 was higher in this study appeared to be cardiac output, was higher if they got drug, lower if they didn't. And in turn, the mechanism by which cardiac output was better, we think, was less preload failure. The right atrial pressures were higher, lower if they didn't get drug. So we think we can tentatively conclude that in ME/CFS, part of the exercise problem is neurovascular dysregulation, because when we give a drug that is known to enhance neural activity or function, they appear to get better. A little bit, and I'll be ending with this, on long COVID. We did a very small study with our Yale progeny, Indy Singh and Philip Joseph and others. We did an invasive CPET approach at the 2 institutions, the Brigham and at Yale. and asked if in long COVID compared to a small group of normal individuals, we had abnormalities. The short answer is these things look frighteningly familiar. So here are the normal controls. These patients were 6 months out from acute COVID. They had long COVID symptoms. Their VO2 peak is 70% of predicted, but look at the variance. Remember not to write them off if it's 80 or even a little higher percent predicted. So it's lower in long COVID. The cardiac output read pulmonary blood flow by FIC is no different from normal, however.
For his chemo appointment.
What is very abnormal is systemic oxygen extraction. So this appears to be that peripheral problem, which we think is left to right shunting in the periphery. There was a type 2 error here with preload failure looking like it's also prevalent. So this is where long COVID lands. So we think both in ME/CFS, we have neurovascular dysregulation and in long COVID. A quick one here in deference to Kathy's comments about undifferentiated dyspnea. Many of these patients with long COVID have undifferentiated dyspnea, and here is their ventilatory inefficiency or VCO2 slope, which is elevated in the patients with long COVID. Physiologically, there are two reasons for that: hyperventilation during exercise or failure of the physiologic dead space to tidal volume ratio to fall normally. To cut to the chase, it's all about hyperventilation and those patients devoid of parenchymal lung disease and devoid of pulmonary hypertension. There's too much hypocapnia, relative alkalemia. For those of you who are interested, we and a lot of collaborators from the Recover Project published this in CHEST, which compared the exercise pathophysiology in ME/CFS to that of long COVID. So I will end there. Thanks to many and hopefully more to come. I think what's happened over 20 years is we've utilized invasive CPET to take a little deeper dive into the pathophysiology of exertional intolerance. And I thank you.
Thank you very much, Dr. Systrom. I do see that there's a couple questions in the chat. I was going to have them answered after Dr. Casaburi gives his presentation, if that's okay with everyone. Dr. Casaburi, would you like to take it away?
I would. Very, very pleased to follow my esteemed colleagues. Let me see if I can get this into presenter mode. Well, I'm going to talk about a very specific issue in exercise testing to expand the utility of the test. And it has to do with finding a way to convince the FDA to use CPET in certifying and validating a certain CPET test for use in clinical trials. This is a sort of an interesting issue. The FDA hasn't qualified any pharmaceutical as being capable of improving the COPD patient's ability to engage in physical activity. Whereas we sort of know that if we give a patient a bronchodilator, they're able to do more. No label is able to say that. And the problem comes down to this. The central problem is the FDA doesn't recognize any performance measure as a biomarker relevant to the patient's ability to engage in activities of daily living. That's the central problem. The COPD Biomarkers Qualification Consortium was founded, 11 years ago now, trying to develop biomarkers and performance outcomes of value in COPD clinical trials. And one of the main subtitles of that is in defining responses to interventions. And the idea was we would define these things, validate them, and then would present them to the FDA for their qualification. The approach that was sort of suggested by the FDA was to take existing data sets, collect patient-by-patient data to evaluate each individual biomarker and performance outcome, and see their use in COPD clinical trials. And again, this is a paper we published in 2013. The organization was sort of interesting. The COPD Foundation is a patient-facing organization, sort of gathered together industry participants, independent contractors, academics like me, advisory boards from the NIH, and advisory regulators, and trying to to compose a group that would do this validation concept. Now, the first suspicion, the usual suspect was, well, let's look and see whether the 6-minute walk can be used as a tool to be used in interventional clinical trials. And this paper was published in the Blue Journal in 2016. I was one of the down authors, co-authors. And in fact, they were able to gather 14,000 patients' data from observational studies, and 4,800 of these were from interventional studies. What they found was that the 6-minute walk was actually a very good disease stratification tool. But when they looked at whether it would respond to a bronchodilator intervention, neither the placebo groups or the active groups showed any benefit on the 6-minute walk at 6 months or a year. So it was inadequate in defining responses to interventions. So we're back to square one. Well, in comes our concepts with constant work rate exercise testing, cardiopulmonary exercise testing. Pulmonary societies guidelines recommend this sort of test to assess response to interventions. It determines how long a task can be sustained, sort of similar in concept to distance that can be walked at a given pace, or how many stairs that can be ascended at a constant rate. This is sort of makes it relevant to everyday activities. Using the cycler ergometer allows precise metering of work rate. The methodology involves designing a work rate for each individual at baseline that can be tolerated for a given period of time. The target is usually around 6 minutes at baseline, and see whether the intervention will prolong that time. And changes in exercise duration in response to intervention is a more sensitive measure of improvement in exercise capacity than other tests. And that was shown way back around the turn of the century. The study by Oga, who exposed patients before and after a bronchodilator, and so how much 6-minute walk distance changed, how much the peak work rate in an incremental test would change, and how much the endurance time a constant work rate test would change. And you can see here that the endurance time of the constant work rate test has a 20% increase, whereas the others have much lower fractional increases. So an attractive test. And we know why this is. We know, especially for a bronchodilator, why exercise tolerance should improve, because if we improve FEV1, we thereby improve the dynamic hyperinflation characteristics, which we can measure as isotime inspiratory capacity increases. This will decrease dyspnea at a given time during the exercise, and thereby improve the ability of the patient to tolerate the exercise test. So a physiologic basis for this to work. What we did was 10 years ago, apply to the FDA and put in a letter of intent that we were going to develop this for qualification, this constant work rate exercise test, as a clinical outcome assessment for COPD clinical trials. We formed up a group, and I noticed that Alan Hamilton, who was my partner in crime in this work, is on this webinar. We set to work and did a lot of work over the last 10 years. Again, organized by the COPD Foundation, was funded, industry put money in a pot, and we contracted for people to receive the data and to analyze the data, and got a couple of academics, Tom Dolmage and Roger Goldstein, to do a literature search. Now, the literature search went like this. We had 4,200 papers in a primary database, but those were weaned down to 191 that studied specifically constant work rate, cycler ergometer, exercise testing, and interventional trials. What we did then was we took that database and selected papers from them to contact people, both in industry and in academia, and made requests for spreadsheeted, anonymized, subject-by-subject data for us to analyze. We made requests for demographic, pulmonary function, physiologic exercise responses, and quality of life measures. And gratifyingly, we got a good response, especially from academic authors, which allowed us to compose it, which I think is a creditable database. So we ended up with, after all our work, in our database, patient-by-patient data, with 8 bronchodilator studies and 15 exercise training studies. We looked at other interventions, but they weren't as robust as these two variables, these two interventions. Well, here's a list of studies, and I don't want you to read each of them, but the key is the sum total of bronchodilator study patients was 2,166, and for the exercise training was 3,400 and 88, total of 5,000 patients. This is an order of magnitude more than has ever been collected for this sort of a study. Well, what does the FDA say? What they want is a well-understood relationship between a clinical outcome assessment to a meaningful aspect of how a patient feels or functions in his usual life. And it's central to the conclusion that the observed benefit is actually a treatment benefit. In other words, an aspect of health that the patient cares about. So we have to sort of frame the outcome measure in this sort of a framework. We published our first paper on this after doing a lot of work in 2022, a conceptual framework for using these endurance time in cardiopulmonary exercise testing, constant work rate ergometry as a patient-focused, meaningful outcome in COPD clinical trials. We discussed how the data process that characterizes COPD has meaningful effects on physical function during everyday life, how the limits in the physical function are directly linked to exercise endurance in people with COPD, how endurance time during this constant work rate exercise ergometry can be objectively measured, yielding consistent and interpretable results. One of the key breakthroughs was to figure out an equivalence between activities of daily living and work rate that we would perform on the cycler ergometer. And this is a table that we constructed, which relates METs to the activity, to the oxygen uptake requirement, and then to the work rate that would be imposed. And here's an example. If the patient wants to climb stairs at a slow pace, well, that would be equivalent to 41.9 watts for a 70-kilogram person. Different weights would be different equivalences, but we can have an activity of daily living that clearly relates to a given work rate. So if you want to tolerate stair climbing at a slow pace better, we'll give you a 41.9 watt test and see if you can perform that longer. We'll infer that you can climb stairs for a longer period of time. And we even have a thermometer here that shows you for given activities what the work rates are equivalent to. So we've linked work rates during constant work rate cycling ergometry to tasks a COPD patient would like to be able to tolerate for a longer period of time. The next paper was our publication of the integrated database that we had collected from these interventional studies, published again 2 years ago. The final data set included, as I said, 8 bronchodilator studies, 2,166 participants, 15 exercise training studies, 3,488 participants. The database includes 71 variables per participant, comprising demographic, pulmonary function, and physiological response data. Now, not all patients in the database have all these variables, but a large number of patients do for each of them. In particular, for the bronchodilator intervention group, the data set was further organized according to treatment groups. First of all, placebo interventions, and then active treatment groups, which were a variety of bronchodilators and some inhaled steroids along the way. But we lumped those and didn't analyze them according to the specific agents, but partially because we had agreed to do that with the pharma companies that contribute the data. So the definitive manuscript in the series is now in press in the Annals of ATS. We describe the measurement properties of constant work rate cycling endurance time and discuss the use of exercise endurance improvements to evaluate treatment efficacy in COPD clinical trials. And specifically, we provide evidence of validity, reliability, responsiveness, and interpretability. All these are jargon words that are important to validate and measure of this performance outcome measure. This is the database, what these patients look like for the bronchodilator and exercise training group, an average of 62, 63 years. More males than females, but a good representation of women. Body weight on average is average. FEV1s of about 46-48% predicted. So these are fairly representative of the COPD population. First test we wanted to do was to look at construct validity, which is the degree to which the metric behaves in a manner consistent with expectations. One of the expectations is that constant work rate cycle test is a physiologically maximal test. And to validate that, we compared it with the incremental exercise responses that we had in many of the patients that were in the database. And in fact, when we looked at this for a whole range of variables, peak incremental cycle test and end exercise constant work rate test, the values were virtually they were virtually identical, very, very close to each other. Oxygen uptake differences by 30 milliliters, heart rate by 3 beats a minute, ventilation by 2 liters a minute, leg fatigue and dyspnea ratings that were virtually identical, evidence of a maximal test. Known groups validity for the bronchodilator, but not the exercise training intervention. We expected that improvement in lung function would improve exercise endurance only in COPD patients who have a ventilatory limitation to exercise. In other words, only those with severe airflow limitations. And this is one of my favorite slides I've ever produced, ever been part of producing. What this shows is for very severe airflow obstruction, severe, moderate, mild. This is GOLD 1, 2, GOLD 3, GOLD 4 patients. We see the increase in endurance time in this test with the very severe patients, the severe patients, and the moderate patients. And you see that the very severe patients get 2.5 or 3 minutes of improvement, whereas the moderate and mild patients who are not ventilatory limited, and you wouldn't be expected to improve their exercise tolerance with a bronchodilator, have much less. The nice thing, as a rehabilitation advocate, the nice thing is the rehabilitation results, the exercise training results, show both superior to bronchodilator and also constantly improvements irrespective of the severity of the airflow obstruction. So rehabilitation works for everybody. Bronchodilators work best for people with more severe airflow limitation. Known groups validity is demonstrated. Construct validity, further tested by examining the relationship between the change in the endurance time and changes in mechanistically related physiologic and perceptual variables. So one thing we said, well, does the improvement in exercise endurance time correlate with improvement in peak work rate or peak oxygen uptake in the incremental test? And in fact, in 250 subjects, we were able to compare them. The correlations are actually pretty impressive. And then looking at isotime variables, physiologic variables, all these variables here are isotime variables. What is the correlation between this and the change in the endurance time? And I'll just highlight for the patients who are more severely impaired for bronchodilator, that if you decrease dyspnea, if you improve inspiratory capacity, in other words, decrease dynamic hyperinflation, if you slow respiratory rate, there's a good correlation between that and improving exercise endurance time. Again, good demonstration of validity. Retest reliability assessment. They want to see that if you do the test in a stable state at 2 intervention points, so you get similar results. This was done both in patients receiving placebo in the bronchodilator group and patients who were on active drug in the intervention group. And again, the difference between the 2 time points, on average, there's a fair amount of variability, but on average, there's, in terms of number of minutes, 0.22 minutes, 0.01 minutes, minus 0.47 minutes, very little difference between 2 sequential tests. Good retest reliability. And finally, a little bit more foggy and difficult to do, but we tried to derive a minimum important difference for this test. What is a clinically important amount of improvement in exercise endurance, one that can be appreciated by the patient? We do this by anchor-based approaches, by taking mechanistically related changes that are mechanistically related to change in endurance time as a result of intervention, finding those who have published MID values themselves and that we have adequate data in the database. And also, it turns out that you need good correlation between the change in the anchor and the change in endurance time. That's an R of greater than 0.3. We found a number of variables that had established MIDs in the literature. And we then went and, well, I'll just show you the results for one of the variables. We plotted the change in isotime Borg dyspnea, for which we know the MID is 1 point, a decrease of 1, and see how much that improves endurance time. These are each subject's data. That's the regression line there. We then draw a line up from -1 and over to the endurance time and find that the best MID estimate is 1.06 minutes. And we did that for a number of these anchor variables, and found for the bronchodilator studies, for the exercise training studies, that pretty consistently we got values that were near 1 minute. On average, it was about 1 minute. So we declare this minimum important difference for the endurance time to be about 1 minute. This is really a greater number of anchor variables that has ever been employed, with more subjects involved. So in summary, we assert that we provided evidence of validity, repeatability, responsiveness, and interpretability of this performance outcome measure, and that given that exercise endurance is a meaningful aspect of health for COPD patients, established in paper number 1, we believe that this test can be a valuable performance outcome measure in the evaluation of treatment benefit in the context of regulatory and clinical decision-making for COPD therapies. And I'll take a deep breath and thank you for your attention. And expands the utility of CPET.
Thank you very much, Dr. Casaburi. I do notice the couple questions in the chat. I believe they were for Dr. Systrom. The first one was regarding the comment that impairment is equal to VO2 max is less than 80%. Dr. Systrom, are you there?
Yes, I'm here. No, that was just meant as a crude cutoff to give you the overall construct of the our exercise diagnostic algorithm, with an emphasis on the invasive CPET. I said it quickly. One can argue and finesse for sure the VO2 peak, and Z-scores are not provided by MedGraphics, at least commercially, and I think my co-speakers may have some comments on this. They've helped put some of this on the map. We are aware of previous work that suggests the same cutoff of a Z-score around 1.6 can be used for to define normal in terms of the VO2 peak. So I think what's used for PFTs actually could be used here, but not commercially available, to my knowledge.
Okay, and the second question I also do believe was for Dr. Systrom. I think it was during the COVID paper. Was that delta RAP on the y-axis because it seems physiologically impossible to have an RAP of -1?
Yeah, so actually, I'm going to answer that in two different ways. What I showed, it was actually the pyridostigmine interventional trial, the randomized clinical trial in ME/CFS. We had not quite gotten to long COVID yet, but I don't know that long COVID is different, honestly. So that was a delta that was compared to the initial baseline, and I said it quickly. Patients did their initial invasive CPET that we deemed clinically indicated, and then they get drug or placebo, and 45 minutes later, with the existing lines in place, they pedaled again. So that graph was the change of right atrial pressure versus the first bout at maximum exercise. So if they got drug, it went up. If they got placebo, it went down relative to the baseline. Now, nested there, though, is an allusion to negative RAPs in the upright position, and we actually do see them in severely affected patients. And it is a fascinating pathophysiology that needs further work. We know that the right ventricle can coil and uncoil during diastole, and when it uncoils, it can act as a vacuum cleaner and actually apply negative pressure to the gradient. And the pressure gradient that's relevant here, I think, is coming upward against gravity through the big veins, the inferior vena cava, into the right atrium. But I think what we're seeing predominantly is venodilation inappropriately at peak exercise, but there could be an additional factor related to RV uncoiling.
Okay. Are there any other questions for any of our speakers? Okay. Oh,
Sorry, I can say it out loud. This was just that I'm very impressed by that last statement, Dr. Systrom. So is that so you're suggesting basically during isovolumic relaxation of the RV, you get some mildly negative right atrial pressures in the sort of most affected MECFS or PASC patients?
No, that's right. And I don't know that that portion, meaning the intrinsic diastology of the RV, is more dysfunctional in those severely affected patients. I think it contributes in probably all patients and maybe all of us, and that the blood pooling in the lower extremities and the venodilation or failure to venoconstrict is disproportionately down. I'm quite certain of that in the severely affected, but I don't know that lusitropy is different in those patients. It would be a fascinating area to study. Unfortunately, we can't do the cardiac MRIs upright so easily. The other thing that I think plays a role is relatively negative pleural pressures, of course, at peak exercise. That will contribute to a bit of a negative RAP in some patients.
Amazing. Thank you.
Yeah, thank you.
all right. If there's no other further questions, I'd like to thank everyone for coming to the ATS webinar on CPET.